TopMedTalk. Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Majerison here, and of course regular listeners to TopMedTalk will know it was at this time of year that Anaesthesia 2020 was planned in Manchester. Unfortunately, it has been postponed to next year. So, all this week, we're playing some clips from last year's excellent conference. Enjoy.
Hi, Monty Mython here, Editor-in-Chief of TopMedTalk, coming to you live from Anaesthesia 2019 here in the heart of London. We're near at the etc., the ETC venue, which is very near St Paul's Cathedral, and also overlooking the Museum of London. Now, you're going to hear a little bit of clutter in the background because we're out in the trade exhibition, but also where they've just been serving what looked like a very delicious lunch.
It did look good.
It did look good, served in bento boxes, and we're surrounded by salads and fruit, and the message is getting through somehow. So we're here with very special guests, a repeat visitor to TopMedTalk, Professor Paul Wischmeyer from Duke University Medical Center in North Carolina is here because he is giving the Samuel Thompson Browning Oration 2019. Now, you're already going to be confused potentially if you were listening earlier, because there are two Samuel Thompson Browning orations being given this year, the 2018 one and the 2019 one, for reasons that will be explained in greater detail tomorrow by the 2018 lecturer. Right, you tracking? But Paul, welcome back to TopMedTalk.
Thank you. It's great to be here. It's great to be at the meeting.
Yeah, well, and what a powerful topic. We've had you on TopMedTalk before talking about this area.
Yeah.
We've recorded one of your lectures and have it available in TopMedTalk about what patients need their doctors to know, keeping the care in healthcare.
Yes.
Very, very powerful stuff, and you're going to go through that again, which I know is emotionally always takes a toll on you, I believe, when you do it.
You know, it's a passion of mine to try to convey the patient experience, to remind us all, perhaps why we went into medicine in the first place, that caring for the patient maybe should be always foremost, and I think it's very easy to let it escape. But it is, I think I really try to convey what my experiences have been as a patient and things that even up until just a few weeks or months ago when I was a patient once again, and it happens often, I still feel like all of us could do better when we care for people, and I hope perhaps conveying it and putting it out in front for all to see those experiences, it reminds us all to keep the patient as a person and as a human and as someone that might be one of us or one of you someday, foremost in our mind when we provide care to them.
So if folks listening haven't heard Paul's lectures or talks or discussions on TopMedTalk before, there have been some of our most, if not our most popular podcasts that we put out. If you put Wischmeyer, and if you look into topmedtalk.com, well, you found us somehow anyway, but look in the show notes, look at the spelling of his name, put it in our search engine, and you'll get a really great collection of brief and longer interviews and a lecture. And most of it stems off, Paul, just briefly, your own experiences. You've been a patient, been a doctor a long time, but you've been a patient for a longer time.
Yes, going back all the way till I was 15 years old, 1985, quite a while ago, and when I first discovered suddenly, after never having seen the inside of a hospital, much less the outside of one in my life, that I had inflammatory bowel disease, that I had colitis, and suddenly was swept into this world where you seem to be more of a job to be done and a task to be checked off a box at the end of a needle or at the end of a surgeon's blade than a person that was a scared young teenager child, really, almost to some level at that point in my life. And I sadly feel like at times that care paradigm and a lot of what we do in perioperative care hasn't changed very much in 30 years.
So we at the SCA, we recorded at least two interviews about burnout, which I hadn't really focused enough on before. When I heard people talk about Burnout, I was kind of thinking about people who wimp out a bit too easily. I've been completely re-educated now about what it is and how it manifests itself, and I've reflected on quite a lot on that in the last 48 hours. Do you think there's a possibility, because I mean everyone who goes into medicine, not everyone, the vast majority of people who go into medicine, they are very, very caring people. Usually, I mean that's kind of like
I'd like to believe so.
Top of the list when you're trying to vet out medical students, nursing students, whatever it is you're looking for people who care, who have empathy, and you kind of get the impression that when we start in training, we've all got it.
I hope so. I've always wondered, is there a way to teach it? Is there a way to create patients of young medical students or doctors and actually have them care for each other for a day or for two? And their empathy scales, of course, you can measure such things. And would it increase the empathy if you suddenly were the one laying in the bed having to stick an IV into your friend or put an NG tube down your friend's nose, and how you might perceive them, knowing you're going to see them tomorrow as a colleague, not just as a patient?
So do you think there's any, because some of the stories you've told us, like people coming into bathrooms when you're in hospital and when you've been in distress, do you think many of those people were burned out? That they've just they've forgotten, they've stopped noticing?
I do. You know, we are asked to do more and more with less and less time and less people. Work hours permeate the world's care paradigm where residents can't work the hours they worked before. They don't have the connection to the patient, perhaps because they're handing off to each other numerous times a day. We have less of them, and yet the patients we have more and more patients to care for as the world ages. And I do think so. So I think the lists of patients, say a pain service or perioperative service needs to see is exceedingly long, and you're expected to see so many people a day, and to do so you have to keep moving. And so the inconvenience of a patient, like in my case, being in the bathroom naked trying to change an ostomy pouch, slows down the pain team looking at my epidural. And so they just decided a whole group of 10 of them would march right into the bathroom with me naked to look at my epidural as I bled, and nearly had tears in my eyes trying to deal with something I was dealing with. But they had a job to do, and I was one of those jobs.
Now, in reflecting on all of this, part of what we were talking about was, let's call it the curse of the electronic health record and emails and communication. Is I feel it, I see it myself. I definitely see it in the junior doctors and the nurses and other practitioners. They're slaves to getting that record completed and signed off. Absolute slaves to it. Yes. One of the things I didn't like when I worked in America 20-odd years ago was the pressure to keep my billing verifications up. You know, to demonstrate that I'd done stuff by recording the whole time. It seemed to take up a disproportionately large amount of my life, and I think maybe was starting to burn me out and therefore was making me grumpy and less caring. Are we in that world now?
I think we are. You know, as any American physician will attest, we have expectations every day that we have to be doing all the prerequisite charting on patients. You know, if you didn't put it in the electronic medical record, it didn't happen. Even if you may have spent an hour with a patient and their family talking about something that, honestly, you know, last week I was having end-of-life discussions with patients, and they were making big decisions as families. Much of it was just talking about the patient, who they were. I don't know that much of that is relevant to put into a chart, but it was an hour of my time. And so if I don't document something for that period of time, even if I'm not billing for it, I didn't do anything that day. And so it's interesting, the requirements by which we're judged.
Do you think they could do more of that with CCTV and just accept the fact that we're honest people? And if they really, really want to check, they could look at the footage. Because you do nutrition is a major part of your personal life, a major part of your working life.
I do.
But you're also a critical care practitioner. So you round on adult critical care on a regular basis?
I do. That's what I spent all of last week doing.
And that's right. It is called intensive care for a reason. We might have lost sight of that, but it's an intensively caring place.
It needs
is what
to
it should be.
Yep.
And do you think we might be becoming less caring as practitioners because of those requirements, the relentless requirement to document?
I think it makes it more difficult. And there's a certain anxiety that's always in the back of your mind. Did I get all my notes written today? Have I finished all of the writing and signing of the resident and procedure notes? Have I checked all the boxes? Have I ticked all the right billing codes? it's the number one, I would say, negative aspect of being, say, in this case, a critical care physician. I love every minute of what I do. Otherwise, the caring for the patient, the dealing with acute situations, the end-of-life discussions, bringing comfort at the end of life when people need it. But the fact that I'm so worried every day, did I get my notes done? And if I don't get them done by midnight, all of a sudden the notes will change and all the data I had from the template from yesterday will be gone. And so I won't even be able to write the note. And it's challenging.
At Duke, you've got quite a mature electronic health record system now, which overlaps with various different applications.
Yes.
Do the patients have anything where they can give you a star rating, a bit like your Uber driver or your Uber driver does to you? I haven't seen it yet. But
I think there's probably some way. I don't think it's simple probably to access, and I don't know that it happens very much. I've not heard of it happening. I'm guessing that in the outpatient setting, perhaps you might see that more. People have long-term relationships with patients.
When we revalidate here, we have to go through a period of time where we hand out questionnaires to people. It's quite difficult to take the bias and pressure out of it, but you get feedback about your communication skills and caring, etc. Wow. It definitely ups everyone's game.
That's brilliant. I bet it does. I bet it does.
But I'm now sort of tempted by the idea of the fact that from our various different interactions with people that we could get a sort of relentless star rating that goes up and down. Because if your empathy and caring is dropping, if your score was dropped from a 4.9 to a 3.3, you might notice it and adapt. Because it's going to change slowly, isn't it? If it does with those metrics, it's not going to suddenly drop over a week. But if it's trickling down and down and down, you might turn around and say, "Oh yeah, have I stopped caring enough? Maybe it'll come."
Yeah, that's brilliant. I think some sort of assessment and feedback, and I think that's a big thing we in medicine, even for each other, could do better. We had a brilliant group of nurses this week prone our first patient in our surgical trauma ICU, and they came together as a team to take a very challenging patient to prone, actually, for various physical and acute illness reasons, and performed magnificently as a team.
And that is for people listening who are not familiar with this. We usually have people lying on their back when they're on mechanical ventilators. This is the technique where you flip them onto their front, which it seems as though it's very good for the lung.
Yeah, there's a New England Journal paper showing it reduces mortality up to by much as half at long-term outcome points. And so it was time for this patient to have that. And I said, let's do this. And they said, we've never done this in the surgical ICU here at Duke. And, some of the other ICUs do it, but we don't. And the charge nurse had looked at everyone and said, we're going to do this. And the nurse at the bedside said, I'll get all the stuff together. I'll read the protocol. So we do it the Duke way. And because you don't want to not do that. And so everyone and 3 respiratory therapists showed up and 7 nurses and doctor and a physician assistant PA. And it happened flawlessly. The patient was incredibly stable. And she went from a PO2 of 40 on 80% to a PO2 of 80 on 40%. She came off her pressors the next morning. So it was a brilliant success.
Great therapy.
Yes.
And I'm sure during that great care, because everyone was thinking about their pain and their anxiety.
Oh, they're scary.
But I'm reckoning the team, I'm guessing the team cared a lot more about each other during that as well.
They did. It was a calm, pleasant, supportive interaction, one that I intend to send some kudos through the Duke systems of sending kudos to nurses and teams because they deserve it, and I think we don't do that enough.
So one of the interviews we had the last couple of days that you can listen to, those listening online who haven't got there yet, about burnout, one of the things that was pointed out to us is we relentlessly get pings about things we may not have charted right, or did you do this, or did you... So we're chased the whole time.
Yeah, we do something wrong, we hear about it.
But when do you get the ping about well done for proning that patient?
Almost never.
Almost never. We need to do something about that, don't we? Now, Paul, if I may, for the last few minutes, I wanted to shift for a second, because we spoke a little bit in the past. And I'm sorry, everyone, if you're expecting to hear more about Paul's primary subject, but we have got him recorded at length about that before, and there will be more to come. The microbiome.
Yes.
Have I got that right?
You do.
What's a microbiome? Remind us. We've done a little bit of this in the past. What's a microbiome, and where do you find it?
So I would advocate to the audience listening, and it's kind of a sexy topic right now, that the microbiome is what makes us who we are as humans. We have about 30 trillion human cells and about 40 trillion microbial cells in our body. So if you think your cells make you human, you're actually more cellular microbial than you are human. And often people say, well, it's our genetics that make us human. We have 20,000 human genes and somewhere between 20 million or 200 million, maybe even microbial genes. So we're about 1% genetically human and about 99% at any given time microbial. And
so that's the bugs in us.
That's the bugs that live in and on us, our symbiotes, our symbiotic relationship with our friends that actually are 300 trillion friends most of the time we need. They're not the bugs that infect us. They're the bugs that make us whole and live with us and determine things like if mosquitoes bite us or not. For instance, if you go into the woods and you get bitten by all the mosquitoes and your husband, wife, brother, sister don't.
They love me.
It's not because you're sweeter. Sorry, Monty. You're plenty sweet, but that has nothing to do with it. It's the bugs that live on your skin.
I am their top pick.
Yeah, so you have sweet bugs.
Oh, can I do anything about that?
Don't take antibiotics and make them go away. I think that'd be brilliant.
Wow. And you can mess in a bad way with the microbiome on a regular basis, but you can mess with it in a good way as well. And is it just food and drugs, or is it also how you feel, what you do, how you exercise, how you sleep?
Absolutely. It's amazing. Just like you would imagine, our physiology is affected by all those things: sleep, eating, illness. Our microbes are as well, and dramatically so. And of course, some of the biggest perturbations we have as humans are the antibiotics that, unfortunately, we receive all too often as children. We know that children exposed to antibiotics in the first 6 months to 2 years of life have more obesity. They have more autoimmune disease. They have more asthma. They have more other complicating chronic diseases that we're discovering have as much to do with the microbiome as it does to do with our genetics. And in fact, when we're born, our stool resembles our mom's vaginal secretions until 2 years or 3 years of life. But if we're by C-section, it resembles mom's skin in our stool, which is not the way we're meant to immune tolerize.
Yes.
And so actually, C-section children have more obesity, autoimmunity, and other chronic illnesses than children born by vaginal deliveries for millions of years we did. In fact, Rob Knight, who's a microbiome master of the world in many ways, he helped do the American Gut Project.
What's the name again?
Rob Knight. He's a physician at UC San Diego. He was at University of Colorado with me before I came to Duke. When his child was born by C-section, he kicked everyone out of the delivery room and smeared mom's vaginal secretions all over the baby, which I would encourage everyone listening to do too. It's probably the only thing they'll remember I said. But it, in and of itself, may change the future of your child, that simple act.
Oh, wow. And that's scientifically acknowledged, recognized.
Yes. They've charted the microbiome of children. They're strange people that swab their children every day, including their stool.
Yes.
And that chart out what happens to the microbiome of children born by C-section, children born by vaginal delivery, and how the microbiome looks. And there's clearly outcome studies that look at the outcomes of these children as well.
And now I presume breastfeeding's in there as well? Because there's that skin contact as well as...
Sure. Whatever's in the breast milk itself, probably. The data I've not seen is as rich as it is for the C-section versus vaginal delivery, but I'm sure that data is coming. Those are the kinds of studies ongoing now.
And reaching for antibiotics too readily when the child has what may or may not be and usually isn't a bacterial flu or cough or whatever it is. Yes. That's one of the enemies. And I think we're all trying to get better at that antibiotic stewardship, but we all still have this feeling that, it's after 5 days, it's still going, let's go get some antibiotics. Our general practitioners here are very hard to get them out of, which is good, I think.
Yeah, the world is changing.
The world is changing. They are much, much harder to talk into. They want evidence of the fact that it's bacterial, which is good. Yeah,
which is brilliant. There's the other way, then, if you have received antibiotics or if you want to manipulate the microbiome for good, there actually was just a publication that came out today in one of the journals that looked at 2,300 studies of probiotics. So there are definitely populations where it helps. There was a JAMA publication showing taking probiotics after an antibiotic course. The meta-analysis was of 60,000 patients, reduced antibiotic-associated diarrhea 60%.
Right.
And then perhaps even more compelling, there was a paper in Nature, not Nature Immunology or Nature Medicine, but The Nature, 5-page paper where a gentleman from the U.S., a gentleman from India, did a study with millions of NIH dollars where he looked at about 5,000 Indian infants, full-term babies from India, and they randomized them to a probiotic versus a prebiotic, which is like a fiber that the bacteria chew up.
So there's a probiotic is more yogurt-like, is it? Or?
Prebiotic, yes, the probiotic is more yogurt-like. It's the bacteria. It's a bacterial itself, usually a lactobacillus, but there's many others.
And the
is a fiber.
Okay.
Is the fiber that is often, you see in the fibers that we're asked to eat that support our guts. And so they randomized these newborns, these full-term newborns to this, and they found that the newborns that got the prebiotic-probiotic combination had much less respiratory infection, much less sepsis, And all of the infectious incomes was where the primary endpoint were improved dramatically. And so there was this massive effect in a very well done, very large randomized controlled trial. And looking at a population that doesn't really get many antibiotics relative to a Western population or an English population or a U.S. population.
So you can buy them over the counter, can you?
You can.
Yes.
You can. And that's one of the limitations on research is like the U.S. NIH wants us to have FDA-approved probiotics, which are few and far between.
What about antibiotics in food?
Sure, it's a challenge.
Is it? Because are our kids getting exposed to a lot more antibiotics at low levels in food? The reason I asked that, I think I raised it before.
Yeah.
One of my children, who probably, it turned out it was confirmed that they had glandular fever. They had, they ate chicken when we were in America, and they came out in a rash.
Oh, wow.
Consistent with an ampicillin type of rash, which made me read a bit more about how much antibiotic might be. It may have been unrelated, but when I then took a look, and it was, I thought that's been reported before, that you can actually have enough ampicillin in your chicken to get into your body. Is that?
I don't think we know enough yet. The variation in the amounts in food is so variable, and there's so many exposures that affect the microbiome outside of that. But there are large populations now of microbiome collections that exist around the world, including the U.S., where those kinds of questions may be able to be answered someday.
Because I think antibiotics are given quite liberally to animals that end up in our food chain. In
fact, that's a very big selling point: is antibiotic-free meat, antibiotic-free milk, and in the U.S., that's a very popular buzzword in stores.
Antibiotic-free and chlorine-free. We go with this.
Probably.
We have never talked about chlorine in chickens before in the United Kingdom. I'm looking at Nick here if he's nodding at me. We know all about chlorine in chickens now. But anyway, moving on from that, we don't know anything about it really. It's just politicians keep saying,
of course,
chlorine chicken. Paul, thank you very much indeed for your time. Anything last things you'd like to share with us? We look forward to talking to you again soon. Good luck with the lecture. I know it'll be fantastic, but I know it's also emotional for you.
Yeah, I guess just keep putting patients first.
Yep.
Think of that person laying there as your mother, your child, your loved one, and treat them as such. And I think it will make patient care and the patient experience better for everyone and make us all better physicians and caregivers.
And communicate. Remember to tell them
what you're doing. Be honest with them. Yeah. Realize this patient. This may only be someone for a few hours of your life, but they're going to remember you for the rest of their lives.
Let them know you're caring.
Let them know they're caring because they will never forget you.
Paul, thank you for doing this lecture for us. Take care, buddy.
It's an honor.
TopMedTalk.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.topmedtalk.com.